Good evening and welcome to our evening for runners. I'm Fiona Roach. I'm the Business Development Manager here at the Sports Surgery Clinic. Any of you that don't know us, we're an orthopaedic hospital and we specialise in all orthopaedics, musculoskeletal, sports injuries, and we're situated about 10 minutes from Dublin Airport. Now, this evening we've got 3 speakers, and before I introduce the speakers, there are some tabs below. You'll see them on your screen. One is ask a question, so please type in your questions. So after each presentation, we'll be joined live by the speaker and we'll do a Q&A session with them. We try and endeavour to get to all questions. If we don't, we will try and come back to you later on. And some of the questions that are coming in may be covered already in some of the presentations. You will see some other tabs there for strength and conditioning, exercise plan, if you want to book an appointment, you're interested in any kind of fitness screening at all as well. So our first speaker tonight is Dr. Philip Carolan. He's going to be talking about plantar fasciitis. So I'd like to introduce Philip, and afterwards we'll come back and we'll do a live Q&A. Thank you.
Thank you. My talk this evening is on plantar fasciitis. My name is Dr. Philip Carolan. I'm a sports and exercise medicine consultant in the Sports Surgery Clinic in Santry. And I'm also the Cavan team doctor for, and are currently the Ulster Senior Football Champions. I've been asked this evening to talk about plantar fasciitis, which is a very common condition and is seen in many areas of life. I know this evening's talk is to do with running injuries, but plantar fasciitis can affect the general population as well as runners. My objectives this evening are to review the pathophysiology of plantar fasciitis, review the underlying causes. There are numerous treatment methods, and I'll go through them and give some evidence-based facts with regard to these treatments, describe a rehabilitation program, and recommend a return to play program. So in my working week, I can see effectively about 20 odd cases of plantar fasciitis. I see patients that have been referred with initial review with an original problem, or patients who've been sent to me with, have already received a modality of treatments and still have not made any headway in getting over the problem. It is a very, very common condition, and I've just shown some statistics here. It affects 10% of runners. It also affects other athletes such as soldiers, soccer players, basketball players. In America, over 2 million patients are treated per year and has a significant interference in the athletic population and in competition. It accounts for between 11 and 15% of all foot symptoms requiring medical care. So as I said, this slide is an overview of what we might see in the clinic ourselves, between 32 to 40 new presentations a week. It's 15% of all the foot presentations, and it's the 3rd most common running injury. So the pathophysiology of plantar fasciitis. The plantar fascia is a big, thick, broad band connective tissue that spans from the heel bone through the arch of the foot into the toes. It originates in the medial tubercle of the calcaneus, which is the heel bone, and inserts in the proximal phalanges, which is the small bones at the start of the toes, and inserts at the flexor sheaths. It forms both the longitudinal arch and the medial arch, and it supports the arch, or the weight is transferred over the foot from heel strike to toe off. This is just a schematic drawing of the plantar fascia. On the right is a drawing, and on the left is a drawing, and on the right is a cadaveric specimen. You can see it's a big, thick band tissue that starts at the heel bone and fans out into the bases of the toes. The term plantar fasciitis was the original term, but I classically call it plantar fasciosis because it's a chronic degenerative condition that is characterized histologically by cell changes, i.e. fibroblastic hypertrophy, which are the fibroblasts of the cells, causing inflammation and disorganization of the collagen, which in turn causes you to have an inflammatory reaction and causes pain. So simplistically, it is micro tears of the fascia from repetitive trauma, i.e. repetitive foot strike, that causes degeneration of the collagen. And with the degeneration of the collagen, we try and cause a healing response by inflammation. Hence, it's called an inflammatory response, but really is caused by degeneration. So I call it a fasciosis rather than an itis. In medicine, osis is degeneration, whereas itis is inflammation. So you get cycles of tearing and healing, causing chemical mediators of inflammation to produce pain. That eventually causes myxoid degeneration and weakening of the fascia, which causes painful scar tissue and calcification. And this is what causes the calcaneal spur. It's interesting at times when people come into me and say to me, I have a heel spur, doctor, but that's not actually what's causing their pain. It's more the fascia rather than the bone, because the spur is due to recurrent calcification that occurs during the cycle of degeneration, healing, inflammation. So the causes of plantar fasciitis, there's numerous. It's generally seen in people with high arch feet and flat feet. It's seen in people with a tight plantar fascia, with tight and weak calf muscles. If you can appreciate, the plantar fascia attaches to the heel bone, which is intimately linked to the Achilles tendon and hence intimately linked to the calf muscles. So if you have a tight calf muscle, you invariably have a tight plantar fascia. It's also seen in tight hip flexors. There's also the effect of activity. So it's seen with increased mileage, increased weight, also the type of footwear you're wearing, i.e. Big ram running shoes rather than having a nice heel and shock absorbency. And it's also very common in the HLA-B27 spondylar arthropathies. So we describe in medicine, there's two types of risk factors. There's intrinsic and extrinsic. So intrinsic is what the body is made up of, i.e. your anatomical, your functional, age, and inflammatory conditions. Extrinsic is what happens outside the body. So it's your surface, footwear, and the modality of motion. So anatomical, we talk about the high arch foot or flat foot, pes planus, pes cavus, also about the way your foot strike is. Functional is with regard to the muscles, be it the intrinsic small muscles of the foot, or you have a tight gastrocnemius or soleus muscle complex, and they can be weak as well. The age effect, we talk about collagen degeneration as we age. So as we age, your collagen gets weaker. That causes a weakness in connective tissue. Also, gout is a common cause of resistant plantar fasciitis. So the extrinsic causes, of course, are overload, too much, too often, which causes muscle fatigue and breakdown of collagen. Running gait, as we talk about, heel strike, forefoot strike, and of course, footwear. So they're the risk factors for people who develop plantar fasciitis. I talk about intrinsic and extrinsic. We try and talk about the body makeup and the structures that we run on, or the surfaces we play on, and our footwear. So the symptoms of plantar fasciitis is the classical presentation is heel pain first thing in the morning when you get out of bed. This may improve through the course of the day, but tends to hurt again by afternoon and evening. It reoccurs upon standing after prolonged sitting, and it's worse with walking barefoot and walking upstairs. So it's not a very difficult area to do a physical examination on, because most patients describe tenderness to the palpation on the anteromedial aspect of the heel, with ankle dorsiflexion is limited by calf tightness, and they also get pain increased by great toe extension or by standing on their toes, and this is known as Wimsley's test. So this schematic shows the areas that we would see most frequently affected by pain with patients who have plantar fasciitis or fasciosis. I think it highlights the central area on the posterior aspect of the heel or the posterior back of your foot, where 52% is just right on the medial attachment of the plantar fascia, and it can radiate out among the medial, central, and lateral branch. We do get patients who have pain in their forefoot. That generally acts like a nodular plantar fasciitis. We get like lumping in the plantar fascia rather than a pure inflammatory response. So the differential diagnosis that I would deal with when I see patients with heel pain are especially patients who are doing a lot of mileage, are calcaneal stress fractures, fat pad inflammation, so that you can appreciate the plantar fascia acts like a sling or a strut to support the medial arch. And then under the plantar fascia, there's a layer of fat to give cushioning and protection to the whole foot structure. And at times you can get fat pad inflammation or changes in the fat pad that can mimic the pain of plantar fasciitis. Also, there's a tendon that runs very closely to the medial arch called the tibialis posterior tendon, and it can also get injured. One of the things that can commonly mimic plantar fasciitis is medial calcaneal nerve entrapment. And I would normally look into medial calcaneal nerve entrapment if I have a patient that is really struggling with the treatments we've used and still is struggling with quite severe heel pain. So radiology, this is there any value in doing x-rays, MRI or ultrasound? And lots of patients I would see would come in with an x-ray report saying they have a calcaneal spur. So I normally would start off, it's rarely useful, not needed in most cases. And then you get the question, what about the heel spur? I think they're probably negligible. There's about a 13% prevalence and they don't cause any pain. And as I showed there, only 5% of those with a calcaneal heel spur complain of heel pain. I think the use of radiology really is for three main issues: is the diagnosis of a calcaneal stress fracture, especially on people who do a lot of running. And also we get a lot of patients who've had chronic plantar fasciitis who present with quite severe heel pain, and it is very useful in diagnosing a tear in the plantar fascia. So as I say, what I use MRI to confirm is an inflammatory response, enthesopathy, an intrasubstance tear, or just chronic thickening of the fascia. So the inflammatory response, you'll see a thickening of the plantar fascia with some inflammatory cells on the dark layer of the plantar fascia. Enthesopathy, this is where a tendon or the plantar fascia itself tugs on the bone where it's attached, and it'll cause some bony bruising or bone edema in the heel bone, which is a sign that both bone and fascia pain are together, and this is more difficult to treat. An intrasubstance tear, you will see that on MRI because you'll have a fluid layer within the plantar fascia, and then the chronic events or the chronic people, you'll see a big thickened plantar fascia and possibly some bone edema. So regard to the helpfulness of this modality is that under the layer, the line of inflammation, enthesopathy, we have an idea of what sort of exercise program we might put them on, i.e. intrinsic exercises for their foot, concentric and eccentric and posterior chain exercises. So we break them up again in what we would feel is the best modality of treatment, i.e. Depo, which is a steroid injection, ESWT, which is shockwave therapy, ACP, which is platelet-rich plasma, and chronic that has had some treatment done already, put them in a boot. On the bottom there, you can see I've put in surgical. In my 12 years of dealing with plantar fasciitis, or 13 years of dealing with it, I haven't sent on anyone for surgery for their plantar fascia. This is just an MRI scan of a very thickened plantar fascia just on under the heel bone, and you can see some white area in the heel bone, and that's enthesopic changes. There's a small tear in that fascia, and I would be recommending to that patient that they would have a platelet-rich plasma injection. So that brings me on nicely to treatments. And I get a lot of patients who come into me and they've had some form of treatment done already, or they've gone to foot solutions and have had orthotics made and they're getting no better. So I start off with a simple algorithm that I use, and I tick off the boxes that have been covered or not covered and move on from there. So if running and a lot of physical activity is causing them to have severe heel pain, the first thing I tell them is to modify the activity they're doing and give themselves more rest time. There's a talk about shoe inserts, orthotics, taping, supportive shoes. I do believe with taping and some form of shoe inserts. As I mentioned earlier, one of the causes is high arch feet and flat feet. I'm very easy with regard to orthotics. I just recommend to go out and get simple over-the-counter arch supports. It offloads the medial arch. until their heel pain settles down. And then you can make a diagnosis with regard to an altered gait or other gait to prescribe orthotics. One of the great treatments out there for early stage plantar fasciitis are night splints, and I would prescribe this regularly for a new patient. The stretching programs involve arch, calf, soft tissue, massage of the calf, and ice. We use non-steroidal anti-inflammatories early on, but I wouldn't recommend keeping people on non-steroidal anti-inflammatory medication long-term. And then we move into the interventional stuff that we would regularly use in Santry, either a steroid injection, shockwave therapy, or platelet-rich plasma injections. So the principles of the rehabilitative exercises, you need to have overall flexibility in and put less strain on the plantar fascia. So you need the Achilles to be flexible, the longitudinal arch to be flexible, and the calf. So that involves working on the intrinsic foot muscles, ankle stability, and also looking at the way you run to try and reduce the amount of forces that are going into your heel by causing relaxation and greater calf strength and flexibility. So I would normally talk about Achilles stretching once to twice a day, hanging over the edge of the stairs, barefoot heel toe backward walking while carrying weights, towel toe grabbing for the intrinsic foot muscles. And these are the mainstay of the rehabilitative exercises. There was an interesting paper in the British Journal of Sports Medicine recently where they looked on loading the plantar fascia with intrinsic foot exercises, and it had some effect early on in healing, and the paper was called Load Me Up, Scotty. So it's another one of the newer research has been done on plantar fascia pain. So I would normally say to patients who initially come in to see me, before you get out of the bed in the morning, get a towel, put it around your foot and stretch the plantar fascia for a number of minutes prior to getting out of the bed. Because as I said earlier, the plantar fascia acts like a tendon, and it shrinks at night. So when it shrinks, if you put weight into it first thing, you stretch it, and that causes severe pain on an inflamed or injured tendon. So if you stretch it or get it activated first thing in the morning, before you put it in the ground, the pain will be less obvious. Also, we talk about running a golf ball or a tennis ball, or as this image shows, a tin under the heel of the foot, or under the foot, it helps stretch out the plantar fascia. I suppose it's a form of an oxymoron in the sense that one thing we're saying that the plantar fascia is a strut, and yet we're saying we can stretch it. Both cases are probably true. It does act as a strut to the medial arch, but it also shrinks and acts like a tendon, so it can stretch. So as you can see, the slant board stretch and the stair stretch act like the eccentric exercises from Alfredson for the Achilles, but are very beneficial in treating plantar fascia pain. So I mentioned about the night splint. I'm a firm believer that the night splint is underutilized in the treatment of plantar fascia pain. It's a splint that keeps your foot in fully dorsiflexion at night, so it prevents the plantar fascia from shrinking. There's different variations out there, and I've shown a number of splints, and also the sock third over on the right is known as the Strasbourg sock, and it's less cumbersome than the boot, and a lot of patients find it more comfortable at night. But this would be one of my mainstays of treatment initially for a new patient with plantar fasciitis. There's been a number of studies performed on the night splint, and Bat et al. And Probe et al. In 96 and 99 showed that with the tension night splint and heel cupping, in 100% were cured, and ones that failed with non-steroidal anti-inflammatory stretching and shoe changes, a tension night splint improved their outcome. So there's mixed results, but I would always use it first off. Orthotics. This is a very difficult topic to talk on its own. I'm not a firm believer in prescribing orthotics when people have a normal gait and don't have a normal foot strike. Our biomechanics because of severe heel pain. As I said earlier, I would normally recommend that the patient would go out and buy simple over-the-counter arch supports to give the arch a little bit of support as they are going through a rehab program. There definitely is no evidence to show that getting custom orthotics improves the rate of healing of people with plantar fasciitis. As I said, you know, there's been a number of studies out there in 1999. They randomly assigned to patients to 5 different groups, and over-the-counter arch support full length felt 81% noticed a good improvement. With the custom 3/4 length poly orthotics, only 68% noticed an improvement. The problem with that study was that there was only 3/4 length orthotics used rather than the full length over-the-counter arch supports. So that moves me on to the interventional modalities that I would use, because most of the patients have tried a lot of the stuff that I've mentioned earlier with regard to physiotherapy, calf stretching. And so I would then discuss the types of treatment that I would use, which is extracorporeal shockwave therapy, steroid injection, or platelet-rich plasma injections. Extracorporeal shockwave therapy is non-invasive. It involves using a gun like the pictures here, and you deliver a certain dosage of shocks at 10 Hertz frequency, and you increase the bar of pressure to allow, as patients can tolerate, up to a pain scale of 6 to 7 out of 10. The modality works is a cascade effect. So you put the probe onto the degenerative plantar fascia with the energy transferred across the fascia. It causes an activated healing cascade response, which enhances blood flow into the tissue, which causes tissue degeneration, or tissue regeneration, apologies. So we would normally do shockwave 3 to 4 treatments a week apart, and then get the patient back 2 to 3 weeks after that for a top-up treatment. I find shockwave a very good modality. It's non-invasive, and lots of patients do very well with it. The next option is a corticosteroid injection, which we would do under ultrasound guidance. This is an image of the ultrasound probe and a needle being directed at the plantar fascia, and you can see the ultrasound image on the right-hand side. You can kind of see a little mountain in the middle of the image, and the thick and grey part on top of that is the plantar fascia. I'm slow at recommending a steroid injection straight off. There's definite evidence that it provides quicker pain relief at 1 month, but there's no long-term advantage. There has been a number of studies that have shown that steroid injections, there is a recurrence rate of 45 to 50% at 6 weeks. And the big risk with using steroid is that it is toxic to the plantar fascia, and that it may cause tendon or plantar fascia rupture. In the olden days, this is the only treatment we had, and it was regularly used and was successful. But as I say, the statistics show that 1 in 2 have a recurrence rate at 6 weeks. And a newer treatment that we've started using is platelet-rich plasma, and we use the Arthrex ACP separation kit. What we do is we take blood out of your arms, spin it down in a centrifuge, and then under ultrasound guidance, inject that back into the plantar fascia. The biggest problem with the plantar fascia platelet-rich plasma injection is it does involve a certain amount of immobilization. We put you in a boot for 2 weeks pre-injection and 2 weeks post-injection. So I would generally use this for patients who have a tear in their plantar fascia, or for patients who have chronic fasciosis, and have not seen any result with any of the treatments that have been offered to date. So what it is, it's purely simply whole blood that is centrifuged, that is spun down in a machine to create an increased concentration of platelets with or without the white blood cells. So on the image at the top of the screen, you can see nice golden, clear golden fluid at the top. That's the enriched plasma. And at the bottom, that's the separation layer of the red blood cells and white blood cells. So what's so special about platelets? They activate various growth factors within the tissue, and that makes them special because it enhances an inflammatory response to promote healing and repair of the damaged plantar fascia. The effects of the growth factors on tissues, there's 3 different factors. There's the immediate. it causes a second messenger stimulation, i.e. the macrophages stimulate the tissue to cause interleukin response to cause a healing. That's within 5 minutes. Then early, between 30 minutes and 4 hours, you get messenger RNA stimulation to cause protein synthesis and chemotaxis of further healing healing enzymes to the tissue to promote further healing. And then the late responses, within 24 hours, you get fibroblast mitosis, which then encourages collagen deposits and the rate of healing of the damaged plantar fascia. So PRP is not stem cells. We get asked this all the time, is it stem cells? It's not lipocytes and it's not bone marrow. It's simply platelets in plasma that promote an inflammatory response to promote healing and repair. As I said, it promotes inflammation. So the reason we put you in the boot is to try and let things be absorbed and adhered around the plantar fascia and let things rest for a period of time so there's better uptake of the plasma. We don't allow patients to use anti-inflammatory medication for 72 hours after the injection because it stops the cascade inflammation reaction that does promote the healing of the plantar fascia. It's effective in chronic plantar fasciitis and in tears of the plantar fascia. There's lots of papers being written and they all seem to highlight that plantar fascia pain that has not succeeded with other treatments do very well with platelet-rich plasma injections. So my typical treatment protocol for new patient, so I profile and try and limit the amount of activity to control the abuse of the fascia. I normally give them 2 weeks of anti-inflammatory medication. I talk about ice massage and rolling the medial arch up to 4 times a day. Over-the-counter arch supports, give them a handout on exercises to work on their calf, Achilles and the plantar fascia, and follow up in 2 weeks just to reinforce whether they're doing their exercises, get an MRI to see how badly damaged the plantar fascia is, and then discuss interventional therapies. There are unusual things that can mimic the plantar fascia, as I mentioned earlier, and if patients are still suffering from pain after 3 to 6 months and not responding to treatments, which I may say I do have times throw the kitchen sink at plantar fascia pain involving all 3 modalities of treatment, and if at that stage they haven't responded to treatment, I would always think of other conditions that may mimic it, some like a fibrosarcoma of the tissue, a foreign body within the plantar fascia that is not evident on X-ray or on MRI. The older diseases like Paget's disease or TB, and also gout. As I mentioned earlier, gout is one of these arthropathies that can cause plantar fascia pain to linger despite throwing a lot of treatment in it, and a simple uric acid blood test and treatment of gout gets rid of the plantar fascia pain. The one thing that I see quite regularly is when I've thrown a lot of treatments at the plantar fascia is a nerve entrapment syndrome. I've, in the past year, would have seen probably 6 or 7 nerve entrapments of the medial calcaneal nerve and accessory sural nerve. So if treatment is not going well, I would normally refer these patients on for EMG studies and getting the entrapped nerve flushed with saline and local anesthetic generally helps relieve the pain. Prognosis. The prognosis is excellent for plantar fascia pain, although patients I see who have it don't feel the prognosis is good because they've had it for so long. 80% are generally better in 12 months. The literature explains that it is a self-limiting condition and it can burn itself out, but they cannot put a time frame on it. Most patients who get no treatment and get by through the pain cycles generally would say to me that after 3.5 years that it would burn itself out. We have treatments there to try and help patients, and anyone I see, I would start them into a treatment plan to try and reduce the amount of time that we suffer from heel pain. Surgical intervention is very rare, and I don't think, as I said, I haven't referred anyone for surgery over the 12 years that I've been involved in treating plantar fascia pain. So the take-home messages from this talk is that plantar fasciitis is very common. It's a degenerative condition and not inflammatory. Strength is key. What I mean by that is that your calf muscles and your Achilles need to work synergistically to take the load out of the plantar fascia. Adjuncts do help. The heel raises, the soft heel gel pads, and over-the-counter arch supports are all very beneficial in trying to help reduce the pain. Segmental load is used to offload. So as I said, that new paper in the British Journal of Sports Medicine, Load Me Up. Scotty is trying to load the plantar fascia early, so it reduces down the pain. So that is a new paper that may show added benefit over the next number of years. And as I said earlier, I would normally use shockwave therapy or platelet-rich plasma injections, and that surgery and steroid treatments are rare. Again, I'd like to thank you for letting me give you this overview on plantar fasciitis. I can tell you I'm a sufferer of the condition myself. I had it for a number of years, and I understand and empathize with patients who have it. As I said, I'm a sports and exercise physician, and I work in the sports surgery clinic. And this is a final slide of myself with 3 of the physios who work in the clinic. We're all involved with the successful Cavan Ulster Champions of 2020. Thank you very much, and I'm more than happy to take any questions from you.
Thanks, Philip, for a very comprehensive and interesting talk. Well, the questions are flying in. So we're going to start with Catherine's question. She said Catherine did an 8-kilometer walk with a small bit of light jogging in January, and the next day she couldn't put any weight on her left foot. Took 4 weeks before she could walk comfortably again. MRI showed no injury. She still gets a lot of darts of pain in the base of her big toe after walking or light running. She's asking why.
Catherine, it's a very interesting question. You put a big load into your big toe out on your walk and light jog, and there's 2 bones at the base of your big toe called sesamoid bones, and they have a great risk of getting inflamed, which is known as sesamoiditis, and sometimes you can get a stress fracture. Now, generally, they would settle down after 4 to 6 weeks or even a bit longer. But an MRI, you should see a sesamoiditis, definitely, and you should see a stress fracture. Yeah. There are 2 tendons that insert onto the base of the big toe as well that can get inflamed from overuse or increased forces going into them by doing too much activity too quickly. But the likelihood, it sounds to me, is probably more like a sesamoiditis, which is an inflammatory condition of the sesamoid bone on your big toe, and it generally affects the fibula, which is the one on the outside sesamoid bone. But it's quite common and generally settles down by wearing a hard-soled, firm shoe for 4 to 6 weeks. The only other thing is big toe pain can be related to gout. So, you know, unusual to come on after exercise, but it is something that you need to bear in mind if you've got someone with an unusual presentation with big toe pain, is to probably get a uric acid blood test done to check for gout.
Lovely, thanks, Philip. Mark says, can PF come and go, or is it mainly a steady increase until it becomes chronic?
Plantar fasciitis, the literature states that plantar fasciitis is a degenerative condition, and if someone gets it, it generally should burn itself out over time. I do see people who would inform me that they've had plantar fasciitis in the past, it disappeared, and now it's come back as bad as ever. It does become a chronic condition, and that's when patients generally require treatment. I can empathize with anyone that has plantar fasciitis. I had it myself for 3.5 years. At the time, I was doing a lot of research on it, and everywhere I read, the literature says it should disappear by itself or burn itself out. I just did the simple physiotherapy exercises, got no treatment, and eventually woke up one morning and it was gone. But we have treatments out there to manage it, and I definitely would recommend patients get it managed because it does have a big effect on your quality of life. Lovely,
thanks, Philip. Darren says, how long will a shockwave therapy session last?
Okay, that's an interesting question because the shockwave therapy is evolving. There's lots of different machines out there at the minute between radial shockwave therapy. It depends on the machine because the one we use in Santry is a Swiss dollar cast machine, which we treat plantar fasciitis at 10 hertz of frequency, which is a fast pulse treatment. So generally it's 2,500 shocks at 10 hertz frequency, which generally lasts between 8 and 10 minutes. It just depends on how fast the frequency of the shockwave is. When we started off doing shockwave, we had an older machine and it was at 2 hertz of frequency and it took 20 minutes to do it. So it depends on the machine, but there's a set dosage for plantar fasciitis with all the machines. So you just put in the dosage, which, as I say, 2,500 shocks with our machine at 10 hertz, and it counts down itself through the machine.
Okay, thank you. Mary, would you class the recent increase in weight gain as a risk factor for plantar fasciitis? And if so, what would be significant enough weight increase? Okay,
this is a challenging question, because from my talk you would have seen that we do mention that weight gain or carrying extra weight is a risk factor for plantar fasciitis. Anyone who gains some weight is putting a greater force into their heel and into the plantar fascia, which is acting as a strut to the medial arch. I don't blame weight gain on being a true source of plantar fasciitis, because people who are not carrying weight and have a normal BMI get plantar fasciitis as well. Yeah. Athletes get it. You know, a lot of runners, sprinters get plantar fasciitis who are not carrying any weight. So I don't like to use that as a true cause. But of course, if you're putting weight on, it is putting a greater load into the fascia, so it can make it more painful.
Okay, thank you. Question here from Robinson. If X-ray showed a large increase in the size of a heel spur over a couple of years leading to heel pain and surgery, is surgery ever considered, or is increase in heel spur a secondary effect?
That's a very interesting question, and from my talk I kind of mentioned that the heel spurs don't cause pain. You can do X-rays on a population, and there's a prevalence in about 15% of the population who have no pain from a heel spur. 10% of heel spurs might give some pain. Over my time as a consultant, I've never referred anyone for surgery for a heel spur. What causes a heel spur is the repetitive degeneration of the plantar fascia. So as the fascia degenerates, you get the inflammatory response going on, which causes calcification. So it's a chronic evolution of the plantar fasciitis or the plantar fasciosis that causes calcification to make the spur. And if it's going on a long period of time, of course, you'll get an enlargement of the spur, but I still think the pain is generated by the fascia rather than the spur. Okay.
Ashleen, I suffered with my left foot 3 months ago, from metatarsal up to the shin. It's now started on my right foot. Left foot is still not great. Had an X-ray to rule out stress fracture. I've just been fitted with new runners. Is there anything I can do to help with this? Pain is in the top of my feet.
Okay,
this is a big question.
This is a difficult one, because unfortunately, being honest with you, X-ray is not great for diagnosing or ruling out a stress fracture. X-ray will prove that you either have a fracture or not a fracture. Stress fractures don't always give you the dreaded black line in an X-ray. So I can't say you've definitely outruled a stress fracture. Although the way you described the pain radiating up to the shin, it sounds like there's more nerve irritation, and it could be more a neuroma, Morton's neuroma causing the pain. And there is also the risk it can be bilateral, which is both sides and both feet. I suppose if it's not settling and, you know, it's now radiating into another foot, I would recommend probably getting a scan of the foot to make sure there isn't anything else going on. Regard to footwear, I would say I'm not great at giving the names of footwear for patients. My attitude is footwear should be comfortable and supportive. So a firm-soled, comfortable runner is what I recommend to try and help alleviate the pain.
Lovely. Ron, Dr. Philip, plantar fasciosis was explained as micro tears and inflammation. We do also see a substantial group of people younger who have normal findings. Any comments?
Normal findings, I suppose the plantar fasciitis is a degenerative condition and it can affect anyone. I saw someone today, a 15-year-old, who had plantar fasciitis. They have some evidence of inflammatory change within the fascia on scan. It is described as micro tearing, but it's not. It's tearing within the cell particles, which generates on an inflammatory response.
Okay, thank you. Thanks, Philip, for joining us tonight. And yeah, there was a lot of questions there, and I'm sure some more will still come in. I'd like to introduce our next speaker now, Mr. Mark Jackson. And Mark is one of our knee surgeons here at the Sports Surgery Clinic, and he's going to be looking at injuries of the knee, and he will join us live for Q&A afterwards. Thank you.
Hi and good evening. Thanks for registering for this evening's session. Hopefully we can talk about things that are of interest and pass on some useful information. It's quite a big topic. I just want to convey some of my own personal thoughts and educate on some of the issues that we will commonly see, runners in particular. So just to introduce myself, my name is Mark Jackson. I work as a consultant orthopaedic surgeon and am now predominantly a sole knee specialist. So I get referrals from across the country, predominantly through general practitioners, physiotherapists, A&E departments and other surgeons. And this can involve treating and assessing patients of all ages, right from the age of 12 up to, well, there's no upper limit really, so often seeing patients well into their 80s and 90s. Children who are under the age of 12 tend to obviously be looked after more through the paediatric system. So I'm based predominantly here in the Sports Surgery Clinic. I also work a little bit in the Black Rock Clinic, but my practice is then split pretty much down the middle between looking after patients with sports-related injuries and issues, sometimes we call these soft tissue injuries, and those that are more degenerative in nature, which for the main means problems of arthritis. So just to go through a few aims of today's talk, clearly we'd all like to look like the runner on the right here, but I just want to give you some basic anatomy so that we can understand the common conditions that we deal with, go through some of the more frequent conditions that I tend to see in the running population, explain often what a role of a knee surgeon can be, and give you then a walkthrough and a talk of some examples of patients I've seen in the last few weeks. Then just finally a few general tips and advice for people out there who are currently running or perhaps wondering about their injury. So just some very simple anatomy, and anatomy is key to any surgeon's life, and we need to know this in a lot of detail. But just basically, if we look at the picture on the left-hand side here, this is a picture of a knee from the front, with obviously all the skin and fat removed. And we can see a few things that we may just touch upon today. So the top is the muscle, the quads muscle, quad meaning four, so there are four bellies of muscle, if you like, that blend together to form a quadriceps tendon that is seen in this area here, blending onto the top of your kneecap. And then below the kneecap is the patella tendon attaching onto the top of your shin bone here in the tibia. And this whole area is called the extensor mechanism, a very, very common source of pain in runners. The iliotibial band we hear an awful lot about, and that's this structure here, but it extends a lot higher than this, right up all the way up towards the pelvis. And if we look at the structures then on the right, with a lot of the muscular and soft tissues now removed, we're going to be seeing the bones, which, as we've mentioned, the tibia being the shin bone, the femur, which is your thigh bone, the kneecap here is the patella is reflected out of the way just for the picture. And now we can see the joint surfaces, which are usually very smooth and low friction. We see ligaments in the middle, so we hear a lot about this fella here, the ACL, the anterior cruciate ligament. And then in between the bones, there are these things called the meniscal cartilages, and you've got one on each side of the joint. And we'll touch upon a few of these issues as we go along. So again, if we look at these pictures, this picture now on the left-hand side of the screen is just a dissected cadaveric specimen with the knee opened up. So again, we see the joint surface here, this lovely, smooth, glistening surface. This area here under what's the LFC, so this is the lateral side of the knee, the lateral femoral condyle. This is how it should look. On the inside of the knee, on the medial femoral condyle, there is a patch here of some wear developing. Not too bad, but it's certainly happening in this specimen, and then ligaments in the middle. If we were to put a camera in the joint down here and have a look, this is what the viewers we get in our keyhole surgery procedures. So this is called an arthroscopy. And the camera there shows us the meniscus here sitting wedged in between the surfaces. And again, in this example here, this is completely normal with lovely white, smooth, articular joint surfaces. And then the last picture here on the right-hand side again shows how these meniscal cartilages, one here and one here, are wedged in and interposed between the weight-bearing portions of the joint. And it is important just to understand the differences when we talk about the term cartilage. The meniscal cartilage is what is often referred to as a torn cartilage. So if someone says they tore a cartilage, they're referring to these things here, the meniscal cartilages. The joint surface cartilage we often refer to as chondral or articular cartilage, and that's these white smooth surfaces. So half my work, as we mentioned, is a lot of sports-related issues and soft tissue injuries. And just to give you a few pictures here, the top 3 pictures are keyhole surgeries looking after meniscal cartilage damage. So here is a tear, and this is when we've removed it. Here we're doing some stitching and repair of a cartilage, and things can get quite complicated. We tend to sometimes offer this in very specific indications and sports injuries only. The bottom 3 pictures is maybe more then of the ligamentous type work that we might have to deal with the middle picture at the bottom being a very typical torn ACL or anterior cruciate ligament. And once we've cleaned it out, and we're putting a new one in for patients who are desiring a return to their sports in particular, it would look like this. So this would be a before picture and an after picture when we've reconstructed and made a new ligament here. And then finally, this last picture on the left is when we have to do open surgery for very complex injuries, when somebody has essentially dislocated their knee and tore apart lots of these structures we're talking about. Then the other half of the work will be the more degenerative and arthritic problems. And just a few examples here of what we might end up having to do for people. Top left, this are the 2 components of what we call a partial or half knee replacement. This is a full total knee replacement. This would be somebody who's having to undergone another knee replacement. So this is a revision total knee replacement. And this is a procedure called an osteotomy. So this is a younger person with arthritis that we're trying to delay this individual getting a knee replacement. But don't assume all these people are old. Plenty of these patients I see are in their 40s and 50s, and it's not infrequently that we're doing knee replacements on people in that age group. Most, however, are going to be into their 60s and 70s. So how common is a runner's knee injury? Well, the answer is extremely common. So you go to any race, you're going to see people like in these pictures all taped up, wearing straps, wearing bandages. And this article here is from the American Journal of Sports Medicine, which is probably our most respected journal within orthopedic surgery and sports sciences, and looked at a 2-year study on 300 runners who were initially uninjured and followed them up prospectively over 2 years. They were aged between 18 and 60, and running for at least 10 miles per week. And at least one overuse injury was sustained in 2/3 of these individuals over that 2-year period, with at least half of those individuals getting more than one injury. The knee was the commonest site of injury, with again almost 30% of all those injuries being at the knee. And the patellofemoral region of the joint, which we've mentioned being the extensor mechanism, was the most common. The most frequent group that were injured were the amateur and inexperienced athletes, the female sex, and the middle-aged runner. So if you picked up an injury, you have a problem, what tends to happen next? People will discuss, usually with friends, their family, maybe some fellow runners. Have people had similar experiences, and what did they do? Next step might now be for people to pick up their mobile phone, type things into Dr. Google, and see what their advice is there online. Maybe they decide to take a break from running for a bit and see what happens, perhaps see a physiotherapist, maybe some treatment has begun. If things go well and things settle down, fine. But if not, maybe then it's taken further. Maybe a sports doctor gets involved, maybe patients go straight to their GP. And then obviously orthopedic surgeons can become involved too. So I would see patients sometimes referred directly to myself, straight from a physiotherapist, or even self-referrals, or sometimes we're the very last people to be involved because everything else has already been tried, tested, and maybe has failed. And when I do see patients, nearly everybody I see is going to have had an MRI scan, and that certainly helps me to give the individual the best diagnosis I can possibly give them, and give them a guide to what the best treatment options going forward are likely to be. So what are the common conditions? We won't go into this in too much detail. These issues here are very, very common. The tendon type pains, so the quadriceps tendon, the patella tendon and the hamstrings, and these issues are also commonly seen. They can be, however, divided up a bit more simply into two groups. We have the overloading and overuse type injuries, and we have the degenerative type problems and injuries. The overload injuries are a bit different. They tend to be fine. They tend to resolve as long as appropriate treatments are initiated, which generally are non-surgical, and these then can be reversed with most individuals attaining a good outcome. They are also in the main preventable. This picture here just shows a schematic picture of the patella tendon being inflamed. Patella tendonitis being a very common condition. The degenerative issues, however, are a bit different. These are irreversible and need a little bit more careful management and advice. Surgery can occasionally play a role. Is degenerative change inevitable? Yes and no. Some people are lucky and they escape and they don't seem to get too many problems, but everyone gets older. Everybody's going to get grey hair and wrinkles, and I'm afraid people's joints do start to show the strains of the aging process. Some just get it a bit earlier in life than others, or more obviously than others. So what is overload and overuse? Well, it can begin really with some risk factors. Those are going to be usually patients who have some inadequate strength or strength imbalances. Maybe they have quite poor running biomechanics and some inappropriate training regimes. And then there becomes this imbalance. And it's the imbalance between what the body can cope with and respond to, what it can heal, and against the load that's being delivered. And if there is too much load and the body can't respond to it and heal and become accustomed to that new pressures and loads, then there is this imbalance and overload problems can begin. The majority, as we've said, are manageable without surgery, and most then will have no long-term consequences with regards to the development then of osteoarthritis. But it is important to have somebody guiding individuals, taking on board advice from experienced therapists, and the sports medicine doctor or GP can sometimes help out, and sometimes investigations are necessary and injections are necessary. Maybe we need to rule out other pathology. Is there an issue with the spine? Is there an issue with the hip? Are there rheumatological conditions? So there are sometimes further investigations that are warranted, but for most that isn't going to be necessary. So what is my role as a surgeon? Well, I can be good cop and I can be bad cop. We need to obviously assess the condition. We need to usually take a good history. We'll examine the knee and see what we find. Help then come to a diagnosis. Interpretation of the imaging and giving this context. The radiological reports vary in quality from around the country and from radiologist to radiologist. And it is really just detailing what is seen on the scan. And as we say, we don't necessarily treat the scan, we treat the man. So we have to put it in context for individuals and explaining what is relevant and what isn't relevant. Hopefully though, we are able to then guide people and get them back and keep them running. And if we do that, generally then that's the good cop side of things. However, we also sometimes have to advise on realistic expectations, bring people back down to earth a little bit, and also counsel on the potential long-term issues. And some of my role, as well as being a surgeon, which is obviously what we train to do and what we enjoy, a lot of it can sometimes be a bit of counselling and advising that it's time to perhaps stop running. So the challenge that we face sometimes in a runner's knee is that both of us see it differently, but we have very similar goals. We both want people to be active, want people to stay involved in the things that they enjoy doing, but we also don't want to do this at the behest of having long-term problems. So the runner I see is often very anxious about having some time out, wants to obviously improve their symptoms and their pain, and some patients are often incredibly surprised if they've picked up an injury. There's often an expectation that we're going to be able to fix everything and have a very quick fix for it. You know, maybe saying, I have a race coming up in 4 weeks. I've committed to do a triathlon in Barcelona in 2 months' time. And We also get a lot of individuals currently in the current day and age stating that they want to be able to keep running because it's so important for their mental health. From a surgeon's perspective, I need to make a diagnosis. I need to know what I can offer somebody, and clearly want to give that person the best route possible to their highest possible function. But we do have that responsibility too, that we don't want people to damage themselves irreversibly and warn of potential implications that can occur down the line. So there are, I don't want to offend anybody here, obviously, but there are some challenging runners out there. And the retired sportsman or woman who is a keen runner can be a difficulty. They may have picked up quite a few issues in the past. They may have had cruciate ligament injuries, they may have had reconstructions, they could have had cartilage surgery from their teens and in their 20s, and this is now catching up with them. And that can be sometimes difficult to take. The runner who's constantly injured, going from one injury to another, from their groin injury to their heel injury to their knee injury. Again, these are difficult and challenging people, often don't have quick fixes and aren't necessarily sometimes taking on board some of the perhaps preventative measures that can be instigated. The overweight runner, again, a bit of a challenge, putting a lot of pressure and force on joints. And running, in my experience, for people who are overweight isn't necessarily the best way to control weight, certainly not in the long term, and there's usually a lot of other things that should take priority with regards to diet and lifestyle over just being out running. The runner who has a physical job can be a challenge. Somebody who's on a construction site all day, someone who's farming, who is very heavy on their knees and then expects to be able to run that evening and over the weekend doing long distances. That can be quite a difficult need to manage. The inexperienced and new runner, often in their middle ages, they can be difficult because they're coming into things maybe with a very poor baseline of fitness, and they're enjoying their new running and they're feeling the benefits of being out and about and being healthy and active. And then get somewhat surprised when they run into difficulty and have knee complaints and issues that can't easily be fixed. And then there is the perpetual knee abuser, somebody who isn't listening to the advice, is getting sore, swollen knees, keeping on going, has an operation, keeps on going, has another operation, keeps on going. But eventually, usually the penny does drop, and people come to terms with their challenges. So as a surgeon, one of my roles is clearly who needs surgery. And actually for runners, it's relatively few, but there are some specific indications that we can sometimes help with. But as we've said, the majority of injuries in runners can be resolved with a good diagnosis and expertise in a rehabilitation program. We do need to have some realistic expectations though, and patience is very important, as the change in strength, the changing of biomechanics takes time. And this is not necessarily just measured with a few physio sessions over a week or two. This can take months and months, and it does often require motivation and dedication. So just to go through a few surgical examples of patients I've recently looked after. This is a very elite level runner, in fact hoping to make the qualifying times for the 1500 meters for this year's Olympics for Ireland, and was referred with symptoms of mechanical nature in the knee, symptoms of locking and jamming. And overall it's fairly unusual to see elite level runners with knee problems. So it's a somewhat unusual referral, but he had a very clear problem. He had a condition called osteochondritis dissecans, and what we can see here in the keyhole surgery is me retrieving a loose body that was floating around in the joint, and this has been generated off the joint surface here. And when it moves around in the joint like this, it can get pinched and caught. But as soon as it's removed, the symptoms resolve. And he made a very quick, rapid recovery and was back running within within about 3 or 4 weeks, and is now back up to speed and back on track again, hopefully, for his goals going forward. This again is a common presentation. 41-year-old recreational runner, has a physical job. There was no injury, came on gradually and steadily, but he's now got to the point where he's had to stop running. Pain is interfering with life, maybe sleep, maybe he's waking at night and he's limping. When we put the camera in the knee, this is the problem. This is a tear here in the meniscus in between the joint surfaces. However, the rest of his knee is perfect. This is the other half of his knee with a normal meniscus, normal joint surfaces. These surfaces are normal. So when we take out the tear, which is what this picture is here, so this is the before picture, and this is the after picture, because the rest of his knee is normal, again, he can have a very good outcome. Indeed, he did, and got back into things and settled very quickly. This is a similar type of issue in that there is a meniscal cartilage tear. It is a bit different, it's more degenerative. And again, we can clean this up. And so this is taken to this, but the difference in this case is that there is some joint surface damage starting. So we have to take this a little bit more cautiously, because there is the propensity for this to still cause a few issues and pains. And if this progresses over the next few years, then it could be more challenging for that individual to stay involved in these kind of impact and running type activities. And as is often the way, there are similar symptoms also developing on his other knee. This would be an overload problem. Again, recreational runner, and we've seen quite a lot of that in the last 18 months with people perhaps doing more running than normal and increasing the load, running more days, maybe running more frequently, maybe running for longer distances. And this is a reaction in the bone. So on this MRI scan, this is a view of the knee from the front. So this is the femur, the thigh bone, the tibia here. And in this bit of bone, you can see a white pattern. This is a side view showing the same pattern in the bone. And what this represents is bone stress, bone bruising, if you like, or bone edema. And this is indicative that this bone isn't enjoying this new load and is reacting because it isn't getting a chance to heal. This, though, is in the background of a knee that otherwise looks good. So again, if this is rested and protected, the bone will heal, symptoms will usually subside, but it can take time. And this type of condition can sometimes take at least 3 months, sometimes longer, before we allow that person to then start to up their load and increase the running again. And in the background, need to be seeing a physiotherapist to be working on their strength and seeing if there are some preventative measures that can be put in place before that person returns into their desired activity. This then gets a little bit more challenging because this is now significant arthritis at a young age. This individual again has been a regular runner over a good few years and seems to remember there was an old hurling injury, probably tore his ACL ligament, but didn't need any surgery at that stage. But he's now at the point where on the scan that this is a very worn out joint, and when the camera is put inside the knee, there are areas of bare bone rubbing on bare bone. So this is now 100% game over for this individual. They have to accept that there is no good fix for this and running is unrealistic. But however, there should be other activities we can get this person into: the gym, the bike, cross trainers, weight training, and we can then hopefully maintain some good function over the years, but we'll have to accept there are more major surgeries down the line and we need to delay these for as long as we can. Somebody who's a bit overweight and running, as we've mentioned, can be a challenge. So this individual weighs 120 kilos and is using running as his way to control his weight. However, now he's getting arthritis in and underneath the kneecap here on this scan. He also has a poor program of running, very poor basics, and is weak. So this is very vulnerable to progress. And it won't be long before other areas of his knee also catch up and start to wear down. This is not, again, a surgical case. This is just about education, telling people what's going on, interpreting the scan, and giving the expectations going forward. And again, this individual needs to now look at alternative ways to control weight, as opposed to the impact of activities and running. One final case, again, premature osteoarthritis, again, in a very active individual in their 40s who has been heavily involved in doing triathlons and long distance running over about a 10-year period. And this is on the background of having a previous cartilage surgery about 10 years ago. These are both of the knees. The right knee here is bone on bone with a stress reaction again and bone edema. And on the left knee, less advanced changes. But this right knee in particular is in big trouble. This left knee may settle down. But you know, this gentleman has persisted with his running despite being sore, hasn't really listened to his knees. And by the time he comes to get attention and be reviewed, things have really moved on. And again, this is an individual who probably need treatments down the line, and it is a matter of now delaying this for as long as we can. And then we get the serial knee abuser. So this would be somebody who's very vulnerable to getting problems, a daily runner, someone who every single day goes out running without rest and does nothing else, and has been aware of symptoms over time, but is now getting worse. Still running though, determined to keep running, not prepared to take time out and rest. And as well as the run, will often walk for 10 kilometers a day. So what's happening now is that this person is getting arthritis again, similar to the overweight case we just discussed, where the kneecap is wearing out over the front of the joint. But there's also a stress reaction and a stress fracture here in the inner side of the knee. So again, although this may settle and improve, if she doesn't do this, this can deteriorate quite quickly into a much more significant arthritic problem. So again, education, not necessarily surgery. So a few hard truths about osteoarthritis. It's obviously great that our life expectancy and things has improved, but it does bring with it the challenges of osteoarthritis. And we as yet don't have good medical treatments. So this graph at the bottom right-hand side shows how the rates of, as we say here, the prevalence of arthritis in percentage terms is rising through the age groups. So at 40, at 50, at 60, 70 and at 80. So at the age of, say, 70, 40% of the population, if screened for some osteoarthritis, will find that that's the case. Now, prevalence is different to symptoms. A lot of these people still may be relatively unaware of their symptoms, but if we MRI or X-ray people, there are these findings that are developing. And we can see here the significant increase risk and prevalence in women as compared to men. So everybody there has an individualized risk. We are not all the same. There are clear risk factors. We've touched on a few here, age and whether male or female, but the other risk factors here which are independent are obesity, which plays a massive role now in the patients we see with arthritis at a younger age, and also those that have had significant prior injuries. And then things we can't do much about, genetics. You know, you can follow your favourite football team and find that there are players who are just constantly being injured and some that seem to go through a massively long career without ever picking up much of an injury. And a lot has to do with genetics. How are your limbs lined up? What are the shape of your bones and joints? How is your collagen made up? What are your ligaments like? Are you somebody who's very naturally loose jointed, which can lead to problems? Are you somebody who's very tight jointed, which can lead to problems? What are you a responder to training? People respond differently. Some people's muscle hypertrophy comes very easy, some doesn't. And what are your muscle types? And there's lots of genetic factors that will probably play into osteoarthritis in itself, some of which we still don't really understand. And we have to remember that surgical treatments for arthritis are often significant, and in general are not going to be procedures that are going to allow patients to return into their running activity. So to get towards the end of the talk here, my top 10 tips here for runners would be to stay active, but don't just do running. To get stronger, get some resistance training going, and maybe get a good rehab person to evaluate and improve your technique. Please don't try and use running as your primary weight control measure. There are other things you can do, and it is important to recognize that the running may not continue forever, or you may pick up an injury, so you do need alternative ways. Similarly, don't rely purely on the running to manage mental health issues. This is clearly a complicated matter, but if you suddenly find you're out of running for a period of time, that can obviously add into anxiety and mental health concerns. It's good to get to know an experienced physiotherapist. Usually, unfortunately, there aren't quick fixes or miracle cures, and it is important for individuals to accept that sometimes time out is necessary to try and recover and rehabilitate. And you need to listen to some of the warning signs of irreversible joint damage. So in the main, that's going to be a lot of swelling after activity, stiffness and pain. And if these things are happening, please don't ignore and get somebody to interpret these symptoms for you. However, if all feels good and you're managing your load well and you're training well, it's fine to continue, and people will continue running well into their 40s, 50s, 60s and sometimes beyond. But it's not for everybody at that age group, and we just have to be realistic. In general, even though I'm a surgeon, and it's what we enjoy doing in a way and what we've trained to do, surgery can often be avoided, and it can be a slippery slope. You don't want to just be looking for quick surgical fixes and find within a few years things have got a lot harder to manage. So in summary, we all have the same goals. We want people to be active, we want people to be healthy and enjoy their sports. Most of these conditions that runners will present to us with are not going to necessarily be going straight into anything surgical. And I do encourage you to listen to your knee symptoms. Get them checked out if you're concerned. Commit then to some prevention measures, which will involve some alterations perhaps in your training, and accept that unfortunately injuries are common, and it's relatively common, and you may need on occasion to have a break and some time out. So I hope that makes sense, and hope people have picked up one or two things, and many thanks for your attention, and hopefully if there's any questions I'll be more than happy to try and address those for you. Many thanks.
Thank you, Mark, for that really interesting talk. And we have a lot of questions in. We won't be able to answer them all, but we hopefully get through most of them. So John Morgan's asking about supplements. Are they beneficial in prevention and recovery of knee injury?
Yeah, okay. So supplements is obviously a fairly big topic. The common ones that people talk about are going to be things like glucosamine, chondroitin, the fish oils, and then there's things like turmeric, which is a sort of a popular one that people are purchasing and trying at the moment. Now, from a purely scientific standpoint, the evidence for these supplements is pretty weak. People are welcome if they like to try them, and some patients seem to report they get some benefit, but scientifically there's no good evidence to show that it slows up the process of wear and tear, arrests the process of arthritis, or really gives much symptom relief over placebo.
Okay.
So I always tend to say it's up to the individual. They can try it, and by all means they may get lucky and find it helps them, but I don't tend to routinely say you must be on this supplement or that supplement. And that's the problem with, as we say about arthritis generally, is we don't have great medical treatments as of yet.
Joel says, how do you know the difference between normal aches and pains after, say, a long run, if the aches and pains are normal, and the warning signs of an impending injury?
Yeah, so again, it's, a lot of people might get a few aches and pains. That isn't necessarily a problem. It's the degree of pain and the restrictions it causes maybe afterwards. The warning signs, you say in the knee, is the knee that reacts badly to that activity that evening and the next day. So people may feel that the knee swells within a few hours. Maybe go to bed that evening and waking up with pain, and then coming down the stairs sideways the next morning and limping a little bit, and then it eases off, and then 2 days later maybe they feel they could run again. That's probably that's a bit of a vicious circle that you're getting into. So that's what I mean sometimes about listening to the knee symptoms. That's your knee telling you that there's a problem. I think those are the times when I'd encourage people to get looked at and maybe get some imaging, particularly if there's a lot of swelling, just to make sure that you're not running into troubles with significant chondral damage and arthritic issues. But if it's a little ache that doesn't seem to hold you back too much, doesn't seem to have like a hangover effect, you're not having to take loads of painkillers and anti-inflammatories, a lot of those can probably be ignored. But it's obviously it's going to be different from person to person.
There's a question here from Jennifer. Damaged patella tendon 3 months post-pregnancy, not new to running, had no knee issues before, slowly built up running again to 20 minutes wearing a knee trap. How likely are these types of injuries in returning again, and any tips on how to avoid them happening?
Okay, well, this sounds like, reading the question is a bit difficult when it's specific to an individual, but it sounds like somebody who's returning to running after they've, sort of post-pregnancy. Now, one of the issues of pregnancy is obviously, there is quite a lot of weight gain, puts a lot of stress on the joints, and there is also a lot of hormonal changes. Some of the hormonal changes can lead on to ligamentous laxity and joint pain in itself. And because sometimes a lot of core weakening may happen, so with the pregnancy and the stretching of the abdominal muscles and the stress on the back, there is often a bit of it takes quite a long time to restore strength in and around the core and the glutes. So it's not uncommon then if someone, even if they've been a runner in the past, can return to activity and they're running into a bit of that overload and overuse issue, which we talked about in the talk there. I would think that the predominant thing is to ease back, go back to real basic strengthening conditioning type exercises, work a lot on core, and wearing knee straps Probably, I don't find that particularly useful. I know a lot of patients seem to like wearing them. I find it very difficult often to really explain to patients what they're doing.
Yeah.
So, you know, the tight straps that go underneath on the patella tendon and things. I think you're better off going down a good rehab route as opposed to trying to rely on a strap.
Okay, thank you. Leanne, Mark, my knee hurts when I used to go up and down the stairs, but has eased. Now hurts only when I lunge. It does ease as I stretch my hamstring, my quad. Doesn't hurt when I run. I'm thinking tight bicep femoris or IT band syndrome.
Okay, so this is one of the commonest knee symptoms for everybody, not just runners. So this is patellofemoral pain.
Right.
So front of the knee pain. So it won't be, I think, anything to do with the tight biceps femoris, which for people is one of the hamstring tendons. And I don't think it'll relate usually to the IT band syndrome issues. So it's the loading position of the patellofemoral joint. So it's that going downstairs is sometimes worse than going up. Any single leg squats, split squats, Bulgarian squats, those kind of issues, and a lunge. So my feeling on that brief little history there would be that be much more patellofemoral pain, and that could then be, you know, the crunching and the noises that people get would be very common in those positions as well, usually from the patellofemoral joint. So the rehab will be focused there.
Okay. Brona says she's a keen runner, meniscus resection 10 years ago. Knee pain has resumed in the last 2 years. MRI is showing osteoarthritis, medial compartmental cartilage, meniscal damage. She's been recommended to have a uni knee replacement. Will she be able to resume running after this?
Okay, so this again is some of those challenging conditions that we talked about there. So this is clearly I don't know what age this individual is, but obviously having had a significant meniscal resection in the past has led on to accelerated wear and has now got what seems to be what we call a unicompartmental advanced arthritis. So again, it will depend a little bit on the patient's age, and the unicompartmental knee replacement is a good option for day-to-day life, but not for returning to running, in my opinion. Yeah. So I do partial knee replacements or unicompartment knee replacements often, but these implants are not designed for running. They're designed to give people a better quality of life in their day-to-day routine. People set, you know, activity expectations are going to be for walking, maybe some hiking. If they do well, you're into the next level of activities, which could be your golf, maybe playing some light doubles tennis. And that's as far as I usually recommend people take it. Obviously cycling, gym work, so there's things you can do, but actually going out on the road and running with a knee replacement is not going to be advisable. If you're having a uni knee, you want that to last, and no moving part lasts forever. So if you're in your 50s getting a partial knee replacement, you know, that's a stepping stone to a total knee replacement usually, and you want to look after that knee. So stay active, but don't go into those surgeries with the goal of returning to an impact activity, heavy impact activity like running.
Yeah, thank you. Peter, he's torn his meniscus in both knees in the past 12 months. Can he expect that it's likely to happen again? He's 55.
So again, this is the degenerative meniscus issue. And again, often you do find people who have very similar experiences on both their knees. So somebody who's got meniscal tear on one knee has obviously been followed up by a similar problem on the other side. So those issues at 55 are evidence really of a degenerative type process that's going on. So I wouldn't necessarily be concerned about the meniscal tear in itself happening again. You'd be more worried about the consequences of the damaging meniscus and the damaging joint. So that would mean getting into problems of arthritis. Yeah. So in terms of having the meniscal tear happening again, I wouldn't be too worried. It's more the consequences of having the tear in the first place that I'd be a little bit more concerned about.
Okay. Karen's a 49-year-old runner, currently approximately doing 20 to 25 miles per week, including speed sessions. History of distance running. She's very mild knee pain from time to time, but not problematic on both knees in the last year, making a crunching, grating sound. Should she be concerned?
All right, well, I think it'd be interesting to do sort of a survey on everyone who is in this talk about crunching and grating from the knees. I can tell you my knees crunch and grate all the time. Almost every knee I examine is going to have some clicks and noises. And so crunching and grating in itself can often be very benign and mean absolutely nothing. Or it can sometimes mean there is a bit of wear and tear. And that's going to be, again, around the patellofemoral joint, around the kneecap. So those up and down stairs, clicks and grinds that an awful lot of people experience, generally from the patellofemoral joint. So again, in the gym, the squats, the lunges, the leg presses, the force on the patellofemoral joint. And as I said, it can just be quite benign. And if it's not associated with huge pain and swelling, I wouldn't be too worried.
Okay. Last question from Deirdre. Can chondromalacia be treated with surgery?
Okay, so chondromalacia, all that term means is soft cartilage. And it means chondro, as we talked about, there is the surfaces of the joint, so soft surfaces of the joint. And the common term that you hear is chondromalacia patelli, which is soft cartilage on the kneecap. It's a very umbrella term. It doesn't in itself mean very much. And, you know, chondromalacia patelli is often talked about, and it's not usually very responsive to surgery. So in simple terms, no, chondromalacia does not usually lead to surgery. It's a pathway, it's a process that's going on of the surface of the joint starting to get a little bit damaged. And if it's on the kneecap in particular, most surgeons, most sports surgeons will be nervous to recommend surgery for a bit of damage on the back of the kneecap, because often it doesn't change that much. Yes. Certainly not as much as the rehab probably would.
Okay. Mark, thanks very much for joining us tonight. And we're now going to present our next speaker, which is Colin Griffin. And Colin is looking at risk of running injuries. And Colin will join us afterwards as well for a live Q&A. Thank you.
Thanks.
Hey, good evening, everybody. Thanks for tuning in. So my presentation is going to be covering how you manage the injury risk factors in runners. So just a little bit about my background before I start. I work as a strength and conditioning coach in the sports medicine department, or I'm lead clinician for foot and ankle rehabilitation stream, and also lead our run lab services. I'm also undertaking a PhD in Achilles rehab and lower limb biomechanics, and I'm accredited strength and conditioning coach with the UK Strength and Conditioning Association and the Sport Ireland Institute, and also Athletics Ireland Level 3 endurance coach. And I've also had a background in athletics for the last 2.5 decades. My previous career as a race walker, where I competed internationally at European, World and 2 Olympic Games, and retired after the London Olympics in 2013. And since then took up running as a means to still enjoy keeping fit and taking part in competitions. I suppose it still gives me a feel for the sport, and I work a lot with runners as well, so it's good to have that little bit of a connection. So the outline of the webinar will be looking at the biomechanical demands of running, how that might affect injury risk. We'll discuss some of the common running injuries. Now, again, you will have heard from Dr. Carolan and Mr. Jackson on some knee pain and knee injuries, and Dr. Carolan will cover plantar fascia pain. So again, I'm just not going to touch on those too much, but I'll discuss some of the other common ones. And we'll also discuss the role of strength and conditioning as a means of managing running injury risk factors. So most systematic reviews of running injuries and where they occur show that the knee has the highest, is the most common injury site for running related injuries. So in the most recent systematic review in 2018, 28% of running injuries occurred at the knee, 26% around the foot and ankle area. But the main thing you can take from this is that most running injuries, so probably about 2/3 or 70% of running injuries occur from the knee down. So there's probably a message in that in terms of the biomechanical demands of the lower leg, and how we might maybe try and condition that in our strength and conditioning program. So with running biomechanics, there's basic physics involved here. So when we run, when we strike the ground, it's like a collision with the ground, and the ground sort of gives us, or the earth gives us a force back that goes through the body. So it's like Newton's third law. So for every action, there's an equal but opposite reaction. And if you look at the example here, so if you imagine you're running over a force plate, as in this video here, you'll see that the force increases throughout ground contact. So if I play the video, you'll see foot strike. And if you watch the green line and watch the cursor move up, So there's the initial peak as the ankle sort of decelerates the initial impact, and then there's a second peak as the force peaks as the foot's under the hip. So if I was to stand, or if you're to stand up, your body has to be able to produce force or experience force more than your own body weight in order to not fall over. And if you want to walk or move forward, that force is going to be 1.5 times body weight. And if you jog, it's going to be twice body weight. And if you're running at a steady speed, it's going to be 3 times body weight. And sprinters at max speed will be hitting maybe 5 or 6 times body weight. So the faster you go, the more force, more ground reaction forces you've got to try and cope with. And the more force you've got to try and produce to be able to accommodate that and to propel the body upwards and forwards. So I talked there about that's what the external force that goes through the body. Well, as I said, in order to cope with that, there's internal forces that are going on, and there are lever systems at play here as well. Because when the force goes through the body, our center mass lowers, our knee joint and our ankle joint bend as those forces increase. And that's going to put a big demand on some of the passive structures like our tendons, our ligaments, our cartilage, and so on, while also requiring efficient muscle contractions. So again, if you look at the picture here of Mo Farah in a 10,000 meter track race, you'll see that the red arrow is indicative of the vertical ground reaction force direction, so it goes upwards through the body. And as I said, depending how fast you're going, that can be 2 times body weight. If you're jogging, that can be 4 times body weight if you're running at a steady state speed. But the force going through the Achilles tendon as it stretches, so the calf muscles contract and the Achilles tendon stretches, that can be 6 to 8 times body weight, again depending on the speed. But the contact forces at joint level, so at the ankle joint, that's 10 to 14 times body weight. That's like a suction force where you've got bone-on-bone contact, and that's where the cartilage comes into play to try and help to shock absorb that. So higher joint contact force at the ankle, a little bit less so at the knee, but still significant, so 7 to 11 times body weight. And at the hip, something similar, 7 to 11 times body weight. And again, at the hip joint, being a ball and socket joint, it's like a suction force. So again, it's important that the muscles of the lower leg from the torso down are conditioned to be able to accommodate that efficiently. But what about bone loading? So we would traditionally believe that impact causes increased bone loading, and it does to a certain degree, but the peak bone loading actually occurs during the mid-stance phase. So again, if you look at Mo Farah there in that sort of mid-stance point where his foot's under his hip, his knee is bent as much as going to bend, his central mass is at its lowest point, his calf muscle contractions are at its greatest. That's when peak bone loading occurs, particularly in the shin, so around the tibia. So it comes much later than after initial impact. So it's not just the impact, it's how you can absorb that or dissipate that as your center mass lowers and as your joints continue to flex and as the force goes through the body. So I guess if you ask the question, why do most running injuries occur from the knee down? Well, we know from a lot of studies looking at muscle recruitment and muscle force contribution at different running speeds, we know that even at jogging speeds, our calf muscles are operating at about 80% of their muscle capacity, of their peak force capacity, whereas the quads might be operating more around 60% of it. But if that capacity is low, it doesn't take much for that muscle to fatigue earlier than it should do. And the fatiguing muscle is going to affect how the force is distributed and how it's absorbed. So that's going to cause problems locally. So that can put a lot more load through the Achilles tendon. It can cause a lot more loading around the ankle joint. But also, if the lower limb gets tired, if the ankle area gets tired, those forces tend to shift up towards the knee and around the hip. And that can have a big factor on how the knee is loaded and how the hip is loaded, and perhaps increasing the injury risk on those particular sites. So we can safely say that when we jog, our calf muscles are pretty much our jogging muscles, and particularly our soleus muscle, that deeper calf muscle that it has quite a high contribution to running. So I suppose when you think about running and we look at S&C programs, there's a big emphasis on training the core, training the glutes and so on. And yes, that's important, but we often neglect the calf muscles, which is probably the biggest, probably more important if we're to prioritize things. But as I said, it's probably the most neglected area. So if we just look briefly at the calf muscles, so again, if you look at an MRI image, so if I was to take a slice of my leg from the knee down and look downwards at it, that's what I would see. So the LG and MG, so LG being your lateral gastrocnemius muscle and the MG being your medial gastrocnemius muscle. So if you were to look at someone behind with a bare leg, you'll see those two bulging heads of your calf muscles. And as I said, that's your medial and lateral gastrocnemius muscle. So again, big muscles, quite a big volume. But if you look at the layer deeper than that, the soleus muscle, it's an even bigger muscle. So it is more than twice the volume of the medial gastroc muscle. but when you take into account its short fibers, so again, if you look on the image there on the right, you'll see those short fibers that kind of run at an angle between the borders of the muscle. It means that more fibers can be packed into a volume of muscle, and more fibers means that more force can be produced more efficiently. So it's got a bigger force. Contribution, or bigger force potential. And again, so it allows more energy to be loaded on the Achilles tendon as it stretches, and more energy to be, I suppose, returned efficiently. But the calf muscles are also slow twitch muscles, predominantly slow twitch fiber muscles. So they can produce those big forces, but they can do it over and over again, and they can be less fatigable than, say, other muscles that are more fast twitch dominant. So it's really important that we train the calf muscles to produce those big forces and to be able to recover quickly and to be able to repeat it over and over again. And I said, when we're lacking muscle capacity in the calf muscles, that's when we got issues. And then if we see someone coming in with a lower limb injury, it's probably one of the most important areas that we assess. So if we look at some of the common running injuries, we've got runner's knee, which can be an umbrella term for a couple of different knee pathologies, but most commonly patellofemoral pain syndrome, Achilles tendinopathy, shin splints, or any type of bone stress injuries of the lower leg, calf muscle strains, but again, that could be applicable to hamstring muscle strains or quad muscle strains, plantar fascia pain, and proximal hamstring and gluteal tendinopathy. So they're quite common running injuries. So if we look a little bit at runner's knee, and again, I'm only going to touch this briefly because Mr. Jackson will cover this area in a bit more detail, but the knee joint, being primarily a hinge, is not designed for massive amounts of torsion or rotation. And in order to control that, so again, what you have is an overload to the patellofemoral joint. And that could be a combination of a number of factors. It could be biomechanics, it could be how you recruit your quad, hamstring, and hip muscles in particular, and also the muscle capacity of the calf muscles below it. So when we look at a knee injury, we always assess above and below the area. So the calf muscles below and even around the ankle, and above it we assess the quads, the hamstrings, and the hip muscles. So again, they're quite important. And particularly the quads, particularly the lateral hip muscles, or your hip abductors, so your glute medius and part of your glute max has a role to play in terms of controlling hip internal rotation and hip adduction. And also your lateral hamstrings, your bicep femoris has a role to play as well in controlling internal rotation of the femur or the hip and adduction and controlling that sort of rotation around the knee joint. So there are areas that we would assess, and certainly if we see weaknesses or deficits in those areas, we chase after them in terms with a rehab program. But in terms of running biomechanics, and I'll show you a video in a few slides time, we'll also look and see what the knee control is like when you're running. So look at someone from behind and see does the knee keep rotating inwards, and that might give us clues as to their ability to control those rotations from the hip down and from the ankle up. So Achilles tendinopathy is a common one that we see, and again, as I said at the start, it's the main focus of my PhD. So some of the common risk factors for Achilles tendinopathy, we can separate them into intrinsic or internal risk factors and extrinsic risk factors. So internal risk factors being calf strength. So for people who have poor calf strength, there's been some studies to show that some of them have gone on to develop Achilles tendinopathy. If you've had a previous lower limb injury, now that could be a calf strain, it could be an ankle sprain, it could be a stress fracture of the lower leg. That can alter the recruitment pattern of your muscles, and that can, I suppose, change how the tendon is loaded over time. So if we have a previous lower limb injury and we haven't fully rehabbed it, but we've got back running, we've kind of cut corners, that can put us at risk of developing Achilles tendinopathy. People who have any type of metabolic disorder, people who have diabetes or a risk of diabetes or of poor cardiovascular health can be at risk of developing Achilles tendinopathy, because tendons it's actually quite a metabolically active organ. So they can be quite sensitive to other things that's going on around the body as opposed to just running. So if you look at some of the external risk factors that are associated with this injury, training load, so a big increase in volume or particularly intensity, and that's quite relevant given the last 15 or 16 months with our COVID restrictions and people maybe exercising more than normal because they're working at home and trying to keep fit, or in elite sport where particularly in collective team training and field sports has been curtailed for several months, and in the last 2 months they've got back again, where the training intensity in particular has increased exponentially. That can put people at risk of developing Achilles tendinopathy. Cold weather can be a factor, biomechanics can be a factor. If you had a recent course of quinolone antibiotics, that can put people at risk of developing Achilles tendinopathy in some cases. And also alcohol intake is also associated with a risk of developing Achilles tendinopathy. So again, without going too deep into anatomy here, just use this picture just to illustrate the difference between a healthy tendon and one that has tendinopathy. So tendinopathy is pretty much pain and impaired function in the tendon and the Achilles tendon in this case. So again, what causes pain and impaired function. So in a healthy tendon, as you see there, you get a nice orderly alignment of collagen fibers. So you got it at a very, very small level, and each fiber is kind of wrapped around by a sheath. And between those fibers, you've got little cells called tenocytes. And those cells are sensitive to any changes in load that the tendon undergoes. So when it experiences fatigue, or when it experiences big strains or fast movements, those tendons can become more active, and they can react and cause, I suppose, a cascade of events that can change the structure and the makeup of the tendon. So when the load has been too much and the tendon hasn't had a chance to remodel and adapt to that, you've got a change in the composition of the tendon. You've got more type 3 collagen fibrils as opposed to type 1. So type 1 being good collagen, type 3 being unhealthy collagen, or not necessarily unhealthy, but it's collagen that's not able to withstand sort of elastic strains. You've got those cells become a lot more disorganized. They lose that sort of elongated shape. They become more rounded, and you've got molecules that attract more water. So it gives the tendon more of a swollen or puffy feeling. And then you've also got an ingrowth, especially when the tendinopathy has become chronic. So if it's been going on for several weeks, if not months, you've got an ingrowth of nerve, of blood vessels that normally don't reside within the tendon fiber. They're normally sort of in the space between them, and they tend to migrate inwards, and they leak chemicals that can cause the nerve endings to become more sensitized, and that can give you your pain feedback. And over time, the tendon can sort of degenerate and become more and more deconditioned. So tendons need a stimulant. So total rest is not the answer for treating tendinopathy. We need to try and find a level of exercise that you can do that's not too sore, and try to progress it on accordingly. So tendons like a regular bout of loading. So they like to be weight bearing, they like to have the calf muscles contracting, and they like to have a little bit of strain, around about 6%. So again, this little graph here illustrates what can happen if we are exposed to too much strain and too much loading, or too little. So too much, you develop little sort of micro tears in the tendon, and the cells become more reactive, and it can become more catabolic. So it kind of degenerates, eats away at itself, and it's not able to adapt to that load if it's not given time to do that. If we rest for too long and we don't expose it to enough strain or enough loading, again, the tendon sort of, you get a bit of wastage in the tendon, so it becomes more catabolic as well. It becomes less able to handle regular exercise. So it's important to give it that sort of regular bout of loading. And even when it's sore, we try to find a level of calf exercises that they can do without being too sore. So a small amount of pain is okay, so long as it doesn't worsen as we increase our exercises and increase our running load over time. So a little bit about muscle strain injuries. So, we think of a calf tear or a calf strain or a hamstring strain, and we think about the muscle, but in fact, usually in these cases, you have a tendon tissue that surrounds the muscle, and tendon tissue in some muscle compartments that goes down the middle of it. So like a feather. So you see the example there on the left. And usually the muscle strain occurs close to where there's tendon tissue. So usually where the muscle fibers in the tendon sort of meets, at the muscle tendon junction, or usually there can be a tear within the tendon itself around the muscle. And that can have an impact on the grading of the injury and the prognosis of the injury. So if you've got a tear, say for example in the soleus muscle in the central tendon, so again if you look at the illustration B there, that can take longer to recover than say if it was just a muscle fiber tear. Whereas if you had a small muscle tear that's just the muscle fiber, even if it's close to the tendon, but if it's only the muscle fiber and there's no tendon tissue disruption, that can recover a lot quicker, and you can have less disruption to your training. So it's important that we're clear in the diagnosis. We use MRI imaging to know the grading of the injury, whether it's a 1, 2, or 3, or worst case scenario 4, and whether it's just pure muscle fascia fiber, or whether it's muscle tendon junction, or whether it's pure tendon tissue that's disrupted, and that can impact on it. So again, if you look at the calf muscle on the right hand side, you'll see a cadaver image of the muscle. See the soleus there being stripped off, and you'll see the two heads of the gastrocnemius, so the lateral and medial head. But if you look at the white tissue there, that's on the image, that is the tendon tissue, the aponeurosis. You'll see different, I suppose, segments of white tissue around the muscle, and that's the tendon tissue. So again, usually close to those sites is where the injury occurs. So what about bone stress injuries? So essentially what we know from people who have looked at, we've studied both bone loading closely in response to exercise, and those who've developed either shin splints or stress responses to the bone, or a stress fracture, There's usually like a failed healing response in the bone. So when we run, when we do impact type stuff, when we run or hop or do something that has high impact, we're temporarily breaking down bone tissue, and that gives the bone tissue a stimulus to recover and remodel. So we're constantly exposing it to repetitive stresses and strains, small little bits of micro damage that occur. But again, in normal situation, if you've got a good healthy metabolism, if we have a good structure to our training, we've got enough time to recover quite quickly to that. But if we're not able to adapt to it, and the bone needs more time to adapt and remodel, and they haven't got a chance to recover, well, then we're putting it into mechanical fatigue territory, where then you're at the risk of injury. So basically, you have, I suppose, failed healing response in the bone. And if you look at what happens within the bone, so when we stress the bone, we have formation of osteoclasts and osteoblasts. So osteoclasts is where almost like where the bone sort of eats away at itself, and that sort of allows for calcium and other important minerals to be released. It also prepares the surface of the bone where the injury is, or where the microfracture is, to be ready for new bone to form over that. And then you got osteoblast formation, which is where new bone cells start to form, and the bone starts to line up again. So essentially, when we have a failed healing in the bone, we have more eating than say replenishing. So it's in that sort of energy deficit. So it's important that when we look at people with bone stress injuries, that we have good nutrition intake. So bones need energy to recover, and that we have good strength and muscle capacity in the lower limbs, because that impacts how bone is loaded, and that we are not increasing our training loads too much too soon. So if we look at a few common factors related to running injury, so basically we have a mismatch between load and capacity. So the load we're putting on the body is greater than our capacity to handle that load. And it's a very, very simple way of looking at it. I know there's a lot of, it's very hard to say there's one thing, but there's an interaction of a number of factors. So obviously we try to look when we assess someone, we want to identify any potential overload factors, and then we also assess their capacity. Some of those overload factors can be biomechanics, it can be training load, it can be changed to where you normally train. And it could be non-training stresses either. So if you have a busy work schedule, busy family life, all those things can be an extra load in the body, or a poor night's sleep. If you have, if you look at capacity on the other side of things, that can be poor muscle capacity, high sensitivity to changes in training load. Some people are more sensitive than others. People who are fitter have a higher capacity. People who are less fit have lower capacity to handle training load. And fatigue is similar. So if you have more fatigue, your capacity is reduced. If you have a previous injury, particularly lower leg injury, you're always at a risk of re-injury, because your capacity can be reduced if your rehab wasn't fully complete after that injury. And training age probably comes along to fitness as well. If you have a higher training age, i.e. running for longer than someone who took up running last year, you're going to have a greater capacity to handle those training loads. So this is a nice little graph, and again, I'm not going to go through every little thing in detail, but there's a few little relevant points here. So basically what they did was they were able to quantify the loading of someone who runs, an elite runner who runs a 10K when they're fresh on an easy day, runs a 10K when they're very, very tired, so they're a little bit slower. So the pace is about maybe 25 or 35 seconds per kilometer slower when they're really tired, versus doing 10 1K intervals on the track in spikes. And the main things here, the difference between being fresh, doing an easy run when you're fresh versus when you're very, very tired, your step count can increase by up to 13%. So you have more time on your feet, more steps. If you look at the accumulated vertical ground reaction forces, that is a 6% increase. So just because you're going slower for the same distance, the accumulated loading can actually increase. So you have more of a step count, and your accumulated forces have increased. And look at the Achilles tendon further down. Again, running slow when you're fresh, but running even slower when you're tired, that kind of a 5% increases in Achilles tendon forces. So the main message I would take from that is that running longer and slower when your body's tired, for some people, can be a risk factor. So just important that we maybe, when we're on an easy day, that we just keep some sort of a control on the total volume of running, or the duration of your run. So it might be just better to have your easy run shorter, particularly when you're tired. And if you're an injury prone runner, you know, for people who are well trained, people who are trained at a high level for a good number of years, they can probably handle that better. But for someone who maybe is more injury prone, or has a high risk of injury, just got to be careful in those days, because that's when the damage can be done, because we're not giving the body the best chance to recover, because we're adding more load to it. So some of our common assessments when people present us with injuries or want to try and manage their injury risk factors, we assess strength, we assess their power and plyometric ability, and we also look at their biomechanics, the running biomechanics or running gait. So when we're assessing strength, we want to get a rough idea of whole body strength. So if someone does a squat, whether it's a back squat or front squat, we like them to be able to get to a point where they can put the equivalent of their own body weight or more on the bar and be able to squat 3 reps as a minimum. But again, if someone hasn't squatted before, we're not going to start them on that. They need probably a year or 2 of just basic conditioning to get up to that. But that's when they get above those thresholds, that's probably a good level to be at. And similarly for deadlift, deadlift will probably target the posterior chain muscles, the hamstrings, glutes, a little bit more than the squat would, depending on your technique and how you coach it. And you can always lift a little bit more. So again, we'd be looking at 1.2 times body weight or more for 3 reps. And if you look at calf strength, what we often do is measure them on a force plate. So we get them to stand on one leg with the bar sort of compressed over the shoulders, and basically they try and push. They try to do a calf raise, but the heel hasn't got space to lift. And we would expect them to be able to produce force that's more than 2.5 times body weight. As I said, the calf muscles are big force producing muscles. They can produce those forces. They need to cope with those and a lot more in running. So that gives a measure of total all the calf muscles. But again, we've got 3 calf muscles: our medial gastrocnemius muscle, our lateral gastrocnemius muscle, and our soleus muscle. So because the gastrocnemius muscles cross the knee, so when you bend the knee, that's going to impact how much force they can produce. So when we bend the knee to 90 degrees, we're kind of damping down the force contribution from those gastrocnemius muscles. But because the soleus muscle doesn't cross the knee joint, it doesn't matter whether it's straight or bent, it's going to produce the same force anyway. So if we want to get a rough idea of the soleus muscle force contribution, we'll do a seated calf isometric test where they sit on a seat with their knee at 90 degrees and their heels slightly dropped with the top of their foot on a block. And we get into a seated heel lift where the knee is compressed down and see how much force they can produce. And we like to be seeing people hitting above 1.5 times body weight. And for elite athletes, we try and get them up close to twice body weight. And if we want to get a good measure of their calf endurance, being able to do single leg calf raises, more than 25 of them in 50 seconds. So 1 raise every 2 seconds with good height and good technique and good control. And if you look at reactive strength, so their plyometric ability, we might test them doing a drop jump where they'll maybe drop off a 20 to 30 centimeter box height and try to rebound in less than 1/4 of a second and try to achieve the height of the box that they dropped off or close to that. Or we might get them to hop on one leg and be able to do 10 hops on one leg while maintaining the time on the ground per hop in less than 0.28 of a second without bending the knee too much. So try to use your ankle to hop. And when we look at running biomechanics, we can get a 3D model of someone running, so we can put some marker sets on them. We all got cameras that give us sort of a 3D capture of them. And when they're running, then we can create that sort of stick man image of them. We can work out how much movement occurs at the ankles and the knees and the hips, how much torso movement is going on, and we can look at some of those rotation movements that I talked about at the knee and the ankle. So again, some of the key things we look at here are hip and pelvis motion. So how much hip adduction and internal rotation occurs. Is there a pelvis? Do they have a forward pelvis tilt that increases throughout the stance phase, or does their pelvis drop on one side if you're looking at them from behind? We also look at thigh and shin rotation. We look at the motion of the heel. So can they control their pronation fairly well, or do they collapse and show poor control, which might cause more loading around the foot and ankle area? And we'll also work out their contact time, their flight time. So basically the time on the ground per foot strike and the time in the air and their ability to handle, the ability to control how much the center mass drops and how much the knee bends as force goes through the body. So it's a measure of spring stiffness. So why do we do that? So again, some studies have shown that there are certain features associated with common running injuries. So this study in the UK looked at, so in the side view, people who tend to lean forward a little bit more, people who present with some common injuries tend to lean forward a little bit more, land with the foot a little bit further in front of the body, so the shin at a bit more of an angle and the knee a little bit straighter. So if you look at the illustration A there on the left, versus those who are not injured tend to be a bit more upright through the torso, land with more of a bent knee and the shin a bit more vertically aligned and the foot closer to where the hips are. And if you look from behind, again, give an example there of hip and turn rotation and adduction as well as pelvic drop. So if you look at the athlete, the female athlete in the image A there, you'll see a little bit more drop of the pelvis. So you see the horizontal line going from right to left, a little more tilted. And you see the line from the side of their hips to the center of the knee, a little bit more angled. And that can cause more torsional loads at the knee. It can cause a lot more, puts a bigger demand on the hip muscles, but it can also have a knock-on effect around the foot and ankle too, because if the knee has to, if the hip internally rotates and adducts, and you got that rotation going on at the knee, then there's going to be more adjustments of the tibia over the ankle and so on, and all the foot and around the foot area as well. Versus athlete B, who's able to have a more horizontal pelvis position and less of an angled line from hip to knee. So when we prescribe strength training, some of the most important things we try to cover are some sort of a jump or hop exercise. Depending on the time of year and where they're at in terms of the training program, mightn't be done from the start. Having a double leg whole body exercise like a squat or deadlift, a single leg whole body exercise like a step up or lunge or some variation of it. Having a calf exercise in there, particularly at certain points of the year to try and improve calf muscle capacity, and some sort of a trunk control exercise to try and improve torso control. So in terms of the qualities we want to try and train, if we're trying to improve power or plyometric ability at a high intensity, we'll keep the reps short. So we don't want to be doing these long enough where they're going to get tired and where power diminishes, otherwise we're not training the right things. So reps of about 3 to 6 reps, you know, for 4 sets, taking a longer recovery between sets, because when you do something explosive, you drain the batteries quite quickly and your body needs a bit more time to recover. If we want to try and improve sort of power or reactive strength capacity, we might dial back the intensity a little bit, go for more duration, so we can work up to 20 reps depending on what we're trying to get out of it. If we're trying to improve strength, we'll do rep ranges between 3 to 8 with a 2 minute or more rest between sets for four sets. Again, if we're trying to improve maximal or submax strength. If we're trying to grow muscle, so we're trying to improve hypertrophy, not the most important thing for distance runners, because more muscle mass means more energy expended to try and carry it around. But when someone comes in with an injury, a chronic injury, we often see a lot of muscle wastage and muscle deconditioning. So we see a muscle on one side smaller than the muscle on the other side. So we probably will have to try and give that muscle a stimulus to grow it back to the level of the other side where it should be, because a smaller muscle will, on the flip side, mean less, I suppose, capacity to handle those big forces. And in terms of frequency, if we're not rehabbing, if we're just doing strength training in order to improve performance, and we're fairly good from an injury point of view, twice a week is probably enough. And if we're racing you know, during the busy competition period, if we're racing quite regularly, once a week is probably enough to maintain it. But if we are rehabbing and overcoming an injury, we probably need to have that third in there for at least 4 to 6 weeks to try and front load those adaptations we're trying to get. So I'm just going to take you through a couple of video examples of common exercises and how we might progress them. So if someone hasn't squatted before, we're not going to put up 80 kilos on the shoulders and hope for the best. We're going to try and make sure their squat technique is good, put a chair on them so they can sit back on their heels and be able to squat smoothly, have good technique, and then we can increase weight. So if we get them to do like a goblet squat with a whole like dumbbell or kettlebell into their chest, and they know there's a chair on them, they can sit back on the heels and squat with good, and I suppose reinforce good patterns first. And then if we got that, then we can take the chair away. And if they're well coordinated and balanced, they can sit on their heels and be able to squat and maintain that sort of parallel torso and shin angle. And then we can move to a bar. So I often like, or we can, you know, if we're trying to improve, introduce a deadlift, sometimes a hex bar can be a useful way to do that. It allows you to train with good technique in a safe way. So again, standing in the bar, less of a knee bend. So we're trying to keep the knees a bit stiffer to try and put more tension in the hamstrings. And we're trying to keep the back fairly straight as well. And then we move to the bar from the floor, or maybe from an elevated position on the right there. So again, trying to not bend the knees too much like a squat, trying to target the hamstrings a little bit more, keeping the back fairly straight as we lift. And we should feel the hamstrings and the glutes doing most of the work here. And again, some of our single leg exercises, so a step up. So stepping onto a box. Ideally, if you can stay on one leg, hold that position for a second or two to show that we're balanced, and back down nice and controlled. So really important, it's one of my kind of staple exercises, covers a lot of boxes. And we can do some sort of lunge variation or split squat variation. So an example here on the right of a Bulgarian split squat with a barbell, rear foot elevated, dipping down, not letting the knee travel too far forward. And again, we should feel this closer to the hip area. We shouldn't feel much pressure on the knee doing this. And we want to try and keep our back fairly straight as well. So calf strength, so I mentioned, if we bend the knee to about 90 degrees and have the foot slightly elevated, we can put a big load to the soleus muscle and target that. So doing seated calf raises. And also standing calf raises. So again, I like to go heavy in the calf raises. So a Smith machine or leg press is an ideal way to do that. So standing with the leg fairly straight, pushing up onto the big toe, pausing at the top for a second or two, and back down slowly. And then plyometric exercises, some pogo hops on the spot, Try to be smooth in the ground, spend a bit more time in the air, progress to a drop jump. So again, bouncing off a box, that's a 30 cm box, trying to get off the ground in less than a quarter of a second and rebound almost as high as the box you jumped off. And then maybe doing single leg hops on the spot or single leg hops going forward, as you see there on the far right. So in terms of how this all fits in, we can split the season like a running program into 4 phases or whatever way you want to do it. So general prep phase, we're trying to prepare the body for the bigger running sessions that are going to come. So we're trying to improve tissue capacity, muscle capacity, 2 to 3 sessions per week, working on good movement patterns first. Maybe if we have certain weak spots, if we've had a previous calf or Achilles injury or an ankle injury, we'll do a lot of calf work. If we've had a previous knee or injury, we might do a lot of quad and hamstring and hip work. Or if we've had a previous hamstring injury or recent hamstring injury, we'll do a lot of hamstring and glute work as well. So again, that's the time to try and iron out those things so that you got good muscle capacity before the running training starts to get a lot more demanding. As you move towards specific preparation phase where your running starts to become more of a priority and you're increasing your distance, bringing in those key sessions, twice a week should be enough. We're not going to spend as much time in the gym or doing those exercises, so quality is important. So maybe a couple of exercises done really, really well at a good intensity. So we'll go heavy if that has enough training behind them. And we'll also bring in some plyometric exercises. And as we get close to competition, we want to try and keep that sharpness there, because traditionally that's where distance runners tend to sort of shelve the residency program, because they're training for that marathon in 6 weeks' time. They're going to be tired from all the runs, but when they need to, it's probably the time when they need to get their most strongest. So if we don't train something for a period of 6 to 8 weeks, we can start to lose those qualities. So it's really important that we keep some bit of strength training in there in a clever way, that keeps, I suppose, the week nice and balanced. So we still try and keep in 2 sessions a week, keep it short and intensive to keep that sort of stimulus and edge there. A bit more focus on the plyometrics, keeping in touch with our heavy lifts. And then when we are in season and competing, we try to maintain it 1 to 2 sessions a week. If we're racing it in a given week, 1 is probably enough earlier in the week, a little bit shorter than normal. If we're not racing on a given week, we can probably do a second top-up session. So in conclusion, most running injuries occur from the knee down. Our calf muscles in particular are probably the one muscle group that works close to its full capacity, even at slow running speeds, compared to quads and the hip muscles. So it's really important that we condition them for that. High intensity strength training. So I talked a lot about injury, but it's also associated with improved running economy and performance. And every runner has different needs. So, you know, I try not to, it's very hard to give a one size fits all answer to when someone has a question about a particular injury or what sort of strength training they should do. It's important that they come in, whoever, if they have a S&C coach close to them that's reputable and experienced, get a proper assessment and have their training S&C program prescribed to meet their individual needs. So hope you got something useful from that. I'm happy to take any questions, and I'll just give you a link there to some of my social media channels. I regularly try to share useful information, and always happy to take questions there as well. So thanks again for your attention, and yeah, happy to take questions.
Colin, thanks for that talk. It was really interesting. Now we have a lot of questions coming in, and we're not going to be able to answer them all, but we'll endeavour, as I said before, to get through as many as we can. So first question from Olivia. Olivia, Colin, how influential do you think REDS has in the occurrence of running injuries? What is the management pathway you follow if you suspect this?
Yeah, a good question actually, and quite a common one, particularly probably for younger athletes. And so if any parents of adolescent athletes, doesn't have to be adolescent actually, but it can be, you know, adults too, or coaches. So REDS, for anyone who doesn't understand it, is relative energy deficiency syndrome. So quite common in female athletes, I'd say mid to late adolescent, even into early adulthood. And we would see a lot of them who have like recurrent stress fractures. So metabolism is a big factor. So definitely we would look at energy deficits. Are they getting enough calorie intake at the right time around training? Or are they in a constant state of depletion? You know, looking at like hormonal profile, have they got a regular menstrual cycle? And even just looking at psychosocial factors as well. You know, are they more conscious of their body type and body shape? So with those type of athletes or runners, we would probably have a bit more of a holistic approach here. If it's young athletes, we want to try and involve the parents and the coach, make sure they're all on the same page in terms of how to manage them. They may need nutritionist and psychologist intervention as well. But as I said, it's not just limited to female athletes. Male athletes can be energy deficient, can have recurrent stress fractures as well. So we would certainly be on the lookout for that. And if we suspect that's a factor, we would definitely push the nutrition side of things, careful load management, and making sure that they have a good S&C program, a good balanced running program that suits their needs.
Okay, Thank you. There's a question here actually. Can stress fractures in shins take a long time to heal? I haven't run in 6 weeks. I've been told I have a grade 3 stress fracture. What am I doing wrong? I walk, cycle, swim. Could this be delaying my recovery?
Yes, grade 3 can take a bit longer to heal. Like a standard sort of lower grade stress fracture, you're talking 6 weeks, and probably trying to immobilize for a good bit of that as well to allow for early bone healing and remodeling to take place.
Yeah.
And then you want to get back, you know, once that healing has taken place, you know, you want to try and get back into a gradual exercise program. So get back walking first, be fairly pain-free and have no sort of gait abnormality, then get back into some strengthening exercises, because there will be some muscle wastage if you're in a boot for a while and you're not using those calf muscles and ankle muscles and foot muscles. So definitely want to recondition those. And then you want the body to be able to tolerate some little bit of low level impact. So like doing things like hopping, skipping is a good bone stimulus. Just short 30-second bouts, you know, maybe once or twice a day is a good bone stimulus, and to be able to tolerate that and then gradually get back running, and then obviously make sure that your energy intake is good, calcium and vitamin D levels are good, and nothing more than a low level of pain or discomfort as you progress through it. Obviously, if there's a worsening or there's a high level of pain that's not getting better, you may want to just maybe get reassessed again and see is there incomplete healing, and does it need maybe a more long-term approach.
Okay, thanks. Joan is saying she has Achilles tendonitis for the past 4 weeks, not getting better. Is there anything she can do to speed up her recovery?
Yeah, so obviously you want to be sure of the diagnosis that is Achilles tendinopathy and nothing else. And I suppose, why is it not, like, I suppose find what can you do that's not too sore, and maybe what is the sticking point, you know. So there's a certain level of exercise that you go above where you're going to be sore, but it's really important to find some level of exercise that you can tolerate, and that'll sort of accelerate tendon adaptation to exercise. So finding some sort of calf raise exercise, if it's just a static isometric hold or a half heel lift position, putting tension on the calf muscles without the tendon being too sore, and trying to progress from that. So again, depending on how long it is, you know, some of our sports med doctors might look at an injection, a high volume saline injection that might help to settle the pain a little bit and allow them to exercise a bit more. They might maybe use something like shockwave. From a nutritional point of view, we tend to encourage people to supplement with collagen and vitamin C, which helps to, I suppose, give the tendon the important nutrients it needs to have to repair itself and remodel. But definitely trying to find a level of exercise that you can tolerate and progress on from there. And sometimes people just can stagnate on the rehab program. You know, they can do maybe things that are maybe too easy. The body gets too used to that, and there's no progression and no added stimulus there, and momentum can be lost. So again, it's very hard to cover everything there when I don't know the full picture, but that would be my sort of general advice.
Yeah, lovely. Sam, what is the prognosis when diagnosed with possible Hanglon's deformity, struggling with Achilles problems for 4 years, and there is a bony spur on the right insertion?
Yeah, so that's a tricky one. So so if it's down on the heel, you know, the heel is kind of like a sharp enough bony structure as it is, and if you've got Haglund's deformity, which is an extra sort of little bit of bone growth, you've got that bone kind of digging into the tendon on one side, and if you're wearing shoes, you've got the heel cup of your shoe digging in on the other side, and that could just keep annoying the tendon over and over again. So if it's not responding to rehab, it's, you know, it's worth getting a surgical opinion on that. So I'd be kind of referring someone to back to maybe our sports med docs, or maybe to a foot and ankle surgeon, just to see is another intervention required, because that might be just that just the nature of it might be just you know, constantly irritating it and maybe stagnating progress.
Yeah. Now, we've had a lot of people coming with this question tonight about what do you think about barefoot type of shoes for running or walking in, and generally what type of shoes? So we'll probably answer a lot of people's questions there. Yeah,
a loaded question. Barefoot type of shoes, to be honest with you, I don't like, it's more the transition. So if you're used to wearing cushioned shoes and all of a sudden you go barefoot or you go minimalist and you don't adjust your training load, you're putting yourself at a huge risk of injury, because your lower limb muscles have to adjust a lot to that. They're going to get tired quicker because they're not used to that. And if you're trying to do the same amount of miles or train the same intensity, you're putting yourself at risk of injury. If you're going to do it, for whatever reason you're doing it, there's no necessarily one sort of clear right or wrong here. If you need to do it, just allow a gradual adjustment time. I think it's good to do some exercise in minimalist or even just without shoes, just to try and train the foot a little bit more. But you know, there was a bit of a swing towards minimalist and barefoot maybe in the last 5 to 10 years. It's kind of gone back a bit more. If you look at all the new shoe technology in races, they're going back to more towards cushion shoe with special sort of spring cushioning in them along with the carbon fiber plate. So to be honest with you, I try not to break a formula that's working for you already, unless you've got a very good reason to do it. And I don't know your full history to be able to give you a very precise answer on that.
Thanks. Kevin, lots of calf muscle strains generally at the moment. What's causing this and how long to rest for?
Yeah, probably the simple answer there, given we've seen in the last few months, is you probably have weak calves and trying to ask the calves to do more than they're able to give you when you're trying to run at a certain level. So improving, go back to what I said in the talk there, you know, trying to increase calf capacity because they're so important for running. We demand a lot of them when we're running, and if the capacity is low, it takes a lot less for them to get tired, to get sore, to get spasmed, and for an injury to occur. So load up calf strength, find a manageable level of running that you can tolerate, and then try to increase gradually from there. You know, that would be probably again, without knowing the full picture, that would be my best advice there.
Yeah. Alan says he's got a pain in the space between his Achilles and ankle, originally thought to be Achilles tendonitis. Issue did not resolve with conservative strength exercises. MRI of the ankle was unremarkable. Issue now suspected posterior ankle impingement. Is Corson shot best option from here?
Yeah, that's not my decision. I suppose the clinical test you can do that can differentiate between an Achilles tendinopathy and having a posterior ankle impingement. So if you're quite sore, if you put someone lying on the front, bend their knee, and you try to force them into end range plantar flexion, so you're trying to kind of squash the ankle, bring the heel as close to the top of the ankle as possible. And if they're sore doing that and you give the heel a few taps and it's quite sensitive, there's a good suspicion that it is a posterior ankle impingement. Quite common in dancers who spend a lot of time on their toes in those kind of heel raise positions. It can be managed conservatively, so we do see a lot of them, and if you can prove how you control the ankle. So people who are hypermobile have a lot of space to move, a lot more room for bone-on-bone contact. That can be managed by being more stable through the ankle, being stronger in the calves in those sort of heel raise positions. And if not, then yeah, it's worth getting a sports med doc to have a look at it and see if an injection might help to settle things down a little bit.
Okay. Anne-Marie said, will running on grass reduce forces on the lower legs, and will this have a notable reduction in the risk of injury?
Yeah, so it goes back to the changing shoes as well. It's what you're used to. If you're used to running on road and you go on grass, it can be a bigger stress in the body as doing the opposite. So and you know, it's not, softer is not always better. When you run on softer surfaces, your muscles have to contract a lot more. If the surface is quite soft, particularly grass in, say, winter and springtime, you're going to be on the ground a little bit longer. So muscles have to work a little bit harder, and if they're not used to it, they're going to get tired a lot quicker. Whereas on the roads, you can use your natural spring system better. You can use the tendons a lot more, and they can save the muscle work. So there's pros and cons. I think it's good to, personally, I actually hate running on the grass, but that's my own personal opinion. I wouldn't force that on anyone else. Yeah. Well, I think it's a good idea to mix it up, do some runs, be off the road, do some runs on the road, and even just doing some off-road running can actually help just to improve, I suppose, strength and stability around the foot and ankle complex. So the force going through the body is actually the same. It's just how you coordinate around the joints, around the ankle, knee, and hip can differ.
Okay. Jonathan, what is the right rest period for shin splints from running? I have this from early May. I'm nervous to start running again as I don't want to prolong injury time frame being any longer. Yeah, so again, a few things in that. A shin splint, so it's kind of pain on the lower inside of your shin. And I suppose it's on the spectrum of a stress fracture. So it's like an early stage sort of bone stress response. We're struggling to heal and adapt to what you're asking to do. So there's no set time frame. If it's shin splints and it's a low level of discomfort, some people can run through it, just adjust their training, maybe space out the runs a little bit more. But I would definitely be looking at running mechanics. I would be looking at your running load, making sure there's enough recovery time in there, staying below a threshold of running that you can tolerate that doesn't cause pain or cause a worsening of it. Make sure calf strength is good, because again, it comes down to those bone bending forces. And if the inside calf muscles and the deep calf muscles aren't strong enough to cope with that, it's going to be a lot more fatigue in the muscles and a lot more loading going to the bone. So make sure that's addressed. And then it's a question of trying to progress back up again. You know, you want to be able to,
So for some, say like if someone has a muscle injury or a tendon injury, we can probably let them train with a a level of pain that might be like a 4 out of 10 on a scale. But for a bony type of injury, like a shin splints, maybe a little bit less than that, maybe like a 1 or 2 out of 10 that doesn't worsen. And the main thing is you can increase your running, and whether it's volume, whether it's intensity or frequency, without worsening in symptoms. So it's very hard to give a proper time frame. And also important then, as I mentioned in one of the other questions, is to look at nutrition and look at energy intake, and to make sure there's good recovery and you're in good metabolic health to be able to adapt to what you're asking to do.
One last question here from Gillian. Gillian said she's an ongoing battle with gluteal tendonitis. She's done full rehab, had running analysed. One issue was that she doesn't lift her knees enough, which causes her hips to drop when she strikes the ground. Is the only way forward to continue to try and change her gait?
It's one way forward, and it's important to look at that. So again, as I mentioned there in the presentation, the example of a hip drop that causes compression of the glute tendon against the bone. So if that's happening every stride, just the tendon is going to be constantly annoyed because there's extra compression. So the base of the tendon is getting sort of compressed, squashed against the bone. Definitely important to look at strength around the hip muscles and that as well. So there's a few questions there. People saying, I've tried rehab but haven't worked. It's like there's different ways of rehabbing. It's like saying I've tried running but haven't got any fitter, haven't improved my PB, so running isn't for me, or I need to do something else. But just maybe the way you went about it mightn't be the right way for you. And that's not criticizing anybody else or that, people do things with the best of intentions and under their, but you may need to try a different approach. And you need to maybe get a proper assessment of your strengths and have numbers there that gives you, I suppose, an objective measure where you're at, and then try and chase it. Do a program and try and make sure that you're getting changes in those outcome measures. And if you are looking at running gait, it's grand someone telling you're not lifting your knees enough. Again, I think that's the biggest issue, but the hip drop is one to look at, and you want to make sure you're doing something to maybe modify that a little bit. You mightn't be perfect, but you can maybe reduce that a little bit, and that might take a little bit of load off the glute tendon. But it's really important to have strong hip muscles, and also make sure the level of running you're trying to do is manageable for you, for your individual needs.
Lovely. Thanks, Colin, for joining us tonight. And thanks to everybody that's joined in. We will be sending an evaluation out. We'll be back in the autumn with our next series of public talks. So if you want to go on the website, they'll be on there towards the beginning of August. Enjoy the rest of your summer, and thank you. Good night.